Clinical Monday, the best way to begin a healthy week. Thank you so much for joining us and welcome to it. We call this the Clinical Monday for Oran Pop and Chats. And my name is Nkosi. Today, the spotlight, like I said, it is shining, or rather, it's shined, English, but yeah, it's one of those. We're shining the spotlight on access to health. And joining us for this conversation, it is Shabba Tshiping, all the way from Botswana. Make sure that you send through your questions on the comment section below. Hashtag Clinical Monday on @n_health, that is on X, and also on Facebook. We are live at Oran Popin's Facebook page. You can also find us on www.popn.org. Without wasting any more time, Shabba, happy Monday. Thank you so much for joining us.
Thank you, Ivy, for having me. I'm really honored to be here, to be honest.
Thank you so much for making the time. I mean, we are talking about access to healthcare, and we want to sort of like unpack it from a perspective of Botswana, but also from a perspective of key populations. You know, since I'd like to say you are an expert in the field. You know, what does access to health mean in the context of KP, especially in Botswana?
Oh, okay. When you talk about access to health, especially with KPs, we're actually considering a few aspects. On in terms of accessing health, we're talking about because KP, we're talking about the population that is very sensitive, and we might not want to actually have them actually going away from the facilities because of how the service provision is. So we are actually referring to the aspects of the stigma and discrimination that is within our public health settings that is much hindering them to come to our facilities in terms of how the staff are actually reacting to some of the sexual behaviors that are being practiced by the KP populations. Yes, so those are the aspects that we consider when you talk about access to health.
I got you. Is it difficult then to access healthcare services, you know, as KP, and why is that? Maybe touch on the challenges that, you know, KPs might have. You speak about, you know, sexual practices, or you know, how they engage, and you talk about the difficulties of them accessing, because we want to keep them in these services for better health. But what would be perhaps maybe difficulties in that aspect of them accessing healthcare?
Yeah, KPs accessing healthcare in public health facilities is quite a struggle. In terms of one going to a public health facility, and you might find that a certain facility, when it comes to knowledge, especially to staff members or the clinicians, they are not more knowledgeable on issues faced by the KPs. So some of them, in trying to have that conversation with a client, it's very difficult for one now to be very comfortable to talk about their sexual behaviors, where now you need to explain a lot of what is happening in your own space. And also one thing that we might have realized, the law and policies that hinders KPs to access health and health services in public health facilities. You might find that there are some laws that criminalizes their behaviors. When you talk about sex work, when you talk about people who inject drugs, you might find that most of them, it's very difficult for them to go to a facility and talk about those behaviors because they want to be away from such issues that might make them end up being incarcerated.
Which, I mean, it would be difficult, especially in, you know, I want to say in most countries in Africa, and I think there should be a way, or I don't know, some kind of a challenge with regards to some of these policies or some of these laws that are put in place, then that would hinder accessing, or that would hinder KPs from accessing healthcare. Let's explore some of the factors that you would think that would be intersectional. So you speak about KPs, some of them are sex workers, some of them inject drugs, but what are some of the factors that would be intersectional in terms of, you know, them accessing healthcare or hindering them from accessing healthcare?
already I've talked about the loan policy, which is very common. And the other one I think that I should talk to is the economic status of some KPs having to travel longer distances in accessing health. Did you know that some of KPs who are financially challenged, so they don't have those finances to actually reach to a certain clinic that is maybe 10 plus kilometers away from where they're staying. So those are some of the issues that might hinder them. And the other one is the language barrier. You know, in most instances, non-citizens, you know, when they're not, they don't know the local language, they don't tend to use their language wherever they're from. And when it comes to our clinicians, some of them, they're not really, they don't know the languages of some other countries, especially when you are to assist their client. Then it needs someone who can translate that for you. So a language also is a barrier in terms of accessing health, especially for non-citizens. And that's somehow linked to having seen some of the sex workers being the non-citizens. A lot in Botswana, we are seeing a lot of non-citizens who are sex workers.
What are some of your perspective when it comes to KPs accessing healthcare? And what are some of these? I mean, unemployment would be, you know, one of which I think it would be the biggest, you know, in terms of that, because most KPs are not economically free, stable. It becomes a challenge. I mean, we look at, models like Pop-In that would go into the communities, but you'd find that some of, key populations don't enjoy such, I want to say, privileges of having a healthcare facility coming into the community. But please make sure that you share those with us. We are live on X. It is at @N_health with the hashtag Clinical Monday Access to Health. And also we are live on Oran Pop-In's Facebook page. And joining us for this conversation, it is Shabba Tshiping all the way from Botswana to give us some perspective from the Botswana's point of view in terms of accessing healthcare as KPs. Let's look at the status of healthcare. We compare a lot, and well, I like to make the comparison with South Africa and the world in terms of where South Africa is when it comes to public healthcare, healthcare accessibility, and also it will depend on for that particular conversation who do I have. For instance, I'd compare with Zimbabwe, I'd compare with Lesotho, I'd compare with Ghana. What is the state of healthcare, especially for KPs in Botswana currently?
So if I were to take it a little bit back, when we started implementing key populations prevention program, we started implementing it from the community-based organizations. That's when I think we felt more comfortable to then actually starting it to implement it from the community-based organization, because they've been doing advocacy for the longest time when it comes to human rights and also advocating for free access of health services. Then initially when we were actually moving on and about over the years, that's when we introduced KP implementation into public health facilities, because we are trying to actually close the gap in between of other KPs who are not really comfortable going to the community-based organizations because of this the stereotype being labeled KP organizations. So some felt comfortable going to the public health facilities. So perhaps we might have been missing them, but now that we are implementing the KP also at the public health facilities, that's something that we've been seeing results in terms of where our goal is. And actually going forward, I think that how we're going to keep it implementing in both community-based organization and the public health facility.
And I think it's responding to that. What are some of the HIV strides that Botswana healthcare advocates? I mean, you spoke about advocating for health, and we do know that there is a lot of that being done. Actually, I want to say in Africa as a whole, but specifically in Botswana, what are some of those strides that have been made by these advocates that contribute in ending or fighting HIV against the goals? We have the triple 95,
yes,
and it looks shaky here and there, but let's talk to
definitely. I would say Botswana has moved a milestone in terms of the 95 epidemic goals. Because as far as we're concerned right now, we are at 95, 98, 98, which is a great milestone for Botswana. So I would say since Botswana had adopted the Treat All strategy, we all know that when it comes to health services, in most countries, healthcare services are not for free. But when it comes to Botswana, you might find that it is with some certain health issues where now you need to pay a little fee so that you can be attended to.
Yeah.
But when it comes to HIV prevention and treatment and care, all our HIV-related health services are for free, both for citizens and non-citizens.
Yeah.
So that's something that Botswana, I think, had actually did good in terms of adopting the treat all strategy.
Yeah.
And one other thing that I might want to talk to is the index testing, where now we need to look into your sexual partners in terms of a client who tested HIV positive. Remember, there are other clients that can come forth who are citizens and non-citizens. So we are supposed to look into those so that even if the non-citizens are still within our country, we might as well provide services in terms of HIV healthcare services. And then with Botswana revitalizing on primary health care, where now is talk to the universal care for everyone, regardless of age, race, gender, etc. So they're actually looking into that in terms of now more of healthcare service in terms of an individual. Doesn't solely has to be the government kind of like I don't know how actually I have to put it, like the government responsibility. So each and everyone has to be responsible for their health. That's where now you're engaging anyone at individual level to now say, we're going to engage you from planning, monitoring, as well as results-based, to now give each individual that responsibility of having, being responsible for one's healthcare.
I got you. I like that. Revitalizing. You speak about the treat all strategy, index testing that is getting 95, 98, 98. Wonder where we are in South Africa. But hey, maybe perhaps you can share those strategies with us on how you do it. Last question. You spoke about citizens and non-citizens, and I think there should be a way of us measuring if they are treatment literate or if they are health literate. Do you think there is enough literacy for KPs? You touch on language barrier being one for those that are non-citizens, but do you think that there is health literacy, and do you know what can be done for that to be used to amplify the message around free health services that they can access?
I'll say when it comes to health literacy, it is there, but it's not enough. Of course, yes, we are doing all we can so that it can reach everyone that you're targeting. But when it comes to areas like hard to reach areas, or let me say remote areas, where there is very, very rural, where you can actually walk about 10 kilometers to find a facility, you will also find out that when it comes to education or awareness raising, especially about KPs, it actually takes longer to reach them. And you might find that most of our KPs coming from very rural areas, it takes time for them to get access to this education. So I wouldn't say they're very much literate when it comes to health services, specifically based on their needs as KPs. So you might find that when it comes to urban and urban rural areas, there's a little bit, I don't want to say a lot, but a little bit of it is being done. But we are pushing it to the extent of having that much coverage, so that whenever we are now going outside to target the very rural areas that we usually tend to as to hard to reach areas, we might want to have been done a lot so that everything flows towards where we want to go.
I got you. I know I said last question. Last question.
No
how do you reach the hidden? Because most of KPs are hidden, especially when you look at law or law and policy, and how they that aspect sort of like hinders them to reach, and some would say these organizations that are catering for them, there is a bit of stigma and stereotype towards that. They don't want to go into healthcare because they are treated differently, public healthcare rather, because they're treated differently. How do you reach them then, if then those are factors that would hinder them from accessing healthcare? How do you go about it?
Yes, our KP programs are KP-led, where you use the members of the community to reach out to their peers.
Got you.
So whenever we are conducting outreaches, where now we are coming from a facility to actually go a little bit deeper, where we can be able to find out that we have KPs who are still closeted. So that's how we're using the IPS to reach out, to give them messages, to say we have services that are specifically based on your needs. And perhaps also our clinicians, they go through training so that they can be able to assist our KP clients with that friendly faces, to which we normally refer to as friendly KP services. That consists of the training that they go through, and also those follow-up sensitization to always remind them of what we're actually dealing with. In terms of one being sensitive, we also need to exercise the use of language as a barrier, because if sometimes now you really don't know how to speak to one of the KP members, remember that they're actually going as a community. So if one experiences such, they're actually going to tell others, so that, you know what, stay away from that certain facility because it's not nice, you know. But with the use of the IPS to actually reach out to them, we're actually seeing a lot of them now coming into our facilities.
I've got you. Shabba, Tshiping, my guest today, speaking on accessing healthcare for KPs from the Botswana perspective. Thank you so much for your time.
Thank you, V.